Okay, so we're going to go ahead and get started. So our webinar today is a 2020 MIPS webinar. So we'll be giving you an overview on year 4 of the Quality Payment Program final rule. So that was recently just released in November, about the beginning of the month. So we're happy to be able to present to you all today, before 2020 gets started, the updates for the program, as well as some new requirements, and then also some FAQs that we have available for you all. So on today's webinar, we have Madeline Hernandez, who I'll let go ahead and introduce herself.
Hi, everyone. My name is Madeline Hernandez, and I'm also a MIPS advisor here at NJI. So I work with a lot of the doctors here for MIPS reporting.
And then I'm Patrick Cordes. So I'm another one of the MIPS advisors and one of the analysts here at NJI. And we're happy to bring you this webinar today. So I'll go ahead and jump right into our agenda. So quickly, we'll give you a quick overview on who NJI and who Healthcare Innovation Solutions is. Then we'll go into MIPS, where we'll talk about the overview, so giving key updates for the 2020 program year, as well as information on the performance categories, the performance thresholds, payment adjustments, information about reweighting your categories, and then also a look ahead. So what's in the past for MIPS in the future, going into year 2021, and so on. Then finally, we'll wrap it up with giving information on FAQs, so some FAQs about 2020. We'll give you also some quick information about our 2019 MIPS services, as it's an important time of the year, especially if you have not started to look at your data for 2020. We definitely want to make sure that you have the support there. And then finally, we'll end it with a Q&A session where you all will be able to submit your Q&As through the Q&A box in WebEx, and then we'll answer those questions as they come in. So to start off, New Jersey Innovation Institute and Healthcare Innovation Solutions is where our MIPS services lie. So you're all very familiar with New Jersey Innovation Institute, and then more recently, Healthcare Innovation Solutions. Healthcare Innovation Solutions is the for-profit side of New Jersey Innovation Institute. So we have 3 different areas where we offer services and where we also perform well in. So that's our federal, state, and then also our HCIS, which is our commercial side. So under our federal programs, you may have participated in them, such as our Practice Transformation Network, or our very first ONC grant, where we worked with practices on meaningful use. So with that being said, we've been providing a lot of services over the last 10 years to really bring the best in-class technology and services to you all. And then additionally, from those services, we found gaps in the marketplace. So we found opportunities where clinicians and providers needed help, and then we were able to provide those services to help you all keep up with the changing requirements of those value-based programs. So such as today, many of you do participate with our MIPS registry, which is one of those services that we offer. And then finally, just as we have different federal grants and different federal services we do offer, we do also operate at the state level as one of the designated health IT entities in New Jersey, and then also with our New Jersey Health Information Network. So we work with the Department of Health and then the Department of Human Services as well for our NJ-HIN and some other programs. So kind of just give an outline of where we were to what we do today. So we went from different projects, so those federal grants or those state grants that we received, and turning it into products and services. So as many of you may know, in 2010 is when NJ High Tech was founded. So NJ High Tech was founded with the ONC grant, where we had a team of meaningful use analysts that went out in the field and helped 8,000 doctors in New Jersey get onboarded onto EHRs and to become meaningful users of those EHRs. very in the beginning of that grant, we found out that there was a need for what's called a CMS certified data registry. So if any of you participated in PQRS, you may have participated with our PQRS registry. So our registry has been standing since 2011, and we're happy to still be here today as a MIPS registry 8 years later. And then as you see, through the life of NJ High Tech, we became New Jersey Innovation Institute, and more formally, where you may have participated with our CMS Practice Transformation Network, which was another grant from CMS. And then now looking onwards, we're also in the process of looking for new grants and in phases of securing those grants. So we're looking forward to be able to continue those grant services with everybody, as well as our other services, such as MIPS and other programs that we help you all with today. So just a quick update, Healthcare Innovation Solutions. So what exactly is it? Healthcare Innovation Solutions was launched in 2018 as the for-profit entity of New Jersey Innovation Institute. So New Jersey Innovation Institute is a nonprofit where we do apply for those different grant services and get awarded different grants, and then we offer them through NJI. Our MIPS services, for example, is one of those services that we are able to pinpoint as a service that clinicians need, and then also bring that out as a commercial product. So that's where really the idea of bringing that for-profit side as Healthcare Innovation Solutions came about. So beginning last year, in 2018, we were both the NJI Qualified Registry and HCIS Qualified Registry. In 2019, it's our first year operating fully as Healthcare Innovation Solutions for the Qualified Registry, and our MIPS services and registry will continue to fall under Healthcare Innovation Solutions. So what does that exactly mean about the services that you receive, or really about the MIPS advisors that you may be working about? It's all the same services and all the same people who would be helping you with your reporting. It's the same teams at NJI as well as Healthcare Innovation Solutions. So now to hop into the MIPS overview. So we know that MIPS stands for the Merit-Based Incentive Payment System. And the Merit-Based Payment System was created as a combined program. So it took 3 former legacy programs and combined them into one overall program. So many of us know the Physicians Quality Reporting System, Meaningful Use, or better known as the EHR Incentive Program, as well as the Value-Based Modifier. So MIPS took all 3 of those programs and brought them under one umbrella to be the MIPS reporting system. Now, we know that MIPS is broken up into 4 different categories. So those 4 different categories, clinicians report across them to earn up to 100 possible final score points. So those categories are quality, which is worth 45% of your overall MIPS score, cost, which is 15%, improvement activity is 15% as well, and then finally the promoting interoperability category at 25%. So points from each one of those categories that your clinicians and your practices participate in, they all add up to give you a final MIPS score. Now, depending on that final MIPS score, you may end up with a positive, negative, or neutral payment adjustment. And then that determines what you would receive down the line. Now, just a quick note, because since we are on the topic of 2020 and the final rule for year 3, in the proposed rules from CMS, they did propose that they were going to be changing the weights of both the quality and the cost category to be 40 and 20% respectively. However, they decided not to. So with the release of the final rule, we learned that they did not change the category's performance weight, and they remain at both 45 and 15%. So just as a quick refresher, some terms that we may use throughout the slide, as well as we often use when talking to clinicians and practices and office managers to identify their clinicians and to know whether or not if they're eligible for the program, are listed here. So we know a TIN, that stands for a taxpayer identification number, and that's used by the IRS to identify an entity. And for example, such as for group medical practices or even solo clinicians, we use that when you're doing your billing to Medicare. And then we have your NPI. So that stands for the National Provider Identifier, and that's a 10-digit identifier for individual clinicians. So we all know that we can use your NPI to identify a unique clinician, as well as use that to look up your MIPS eligibility on the QPP site to know if you do have to report for MIPS or not. Finally, we often say TIN NPI, which CMS uses as a combination to create one unique ID and to identify you as a unique clinician. So if you participate across multiple tax IDs, so a doctor that, let's say, participates across 3 practices is billing under 3 different tax IDs, we always want to make sure that we're looking at each one of those instances to see if they do have to report for MIPS or not. Finally, we do have the performance period, which is known as the year. So this year is 2020. A lot of times we'll also refer to that as year 4. And then an important thing to remember is that the corresponding payment year is always 2 years down the line. So when you do report your MIPS 2020 or you're collecting data for 2020, you know that that's going to directly affect your Medicare reimbursements in 2022, which is 2 years down the line. Now, just as far as a timeline for year 4, there was no changes in the timeline for the MIPS reporting program. So this is a very similar timeline that we've seen since the beginning of MIPS. So the performance period starts with the beginning of the calendar year. So going from January 1st to December 31st of 2020, clinicians will care and record patients' data for MIPS. And then finally, directly after the close of the performance year is when we go into the submission window. So the submission window for MIPS 2020 will be from January 1st of 2020 through March 31st of 2021. I'm sorry, just to correct what I said. So the submission window for MIPS 2020 will be from January 1st of 2021 through March 31st of 2021. And that will be known as the data submission period. The deadline for submitting the data is March 31st, 2021, so we will not be able to submit any data after that. And then, as always, we often encourage clinicians to submit data early so that they do have it out of their way and don't have to worry about collecting that or running around at the last minute to be able to complete it. Now, following the data submission period, as soon as you submit your data to CMS, there will be initial feedback available. That feedback available will be your score that you receive for MIPS. And then finally, around in the summer, they always release the final performance feedback. So the final performance feedback will give you your exact score that you're receiving either for your clinician or practice, and then also provide you with the exact payment adjustment that you'll be receiving into the new year. So following the feedback is when that payment adjustment period starts. So for the 2020 reporting, that payment adjustment period is going to start January 1st of 2022, and payment adjustments are applied prospectively to each claim beginning January 1st of 2022. Now we'll transition into the eligibility requirements. So how exactly is a clinician eligible for MIPS? That's what we'll go over in these next couple of slides. So going from 2019 to 2020, there is no changes in the types of clinicians that were eligible for the MIPS reporting. So the clinicians that are eligible are physicians, physician assistants, nurse practitioners, clinical nurse specialists, CRNAs, clinical psychologists, physical therapists, occupational therapists, audiologists, speech language pathologists, registered dietitians and nutritionists, and then groups of those clinicians as well. So just noting back to 2019, we did see a change in 2019 that added those new clinician types. So previously, physical therapists, occupational therapists, audiologists, and so on were not required eligible clinicians for MIPS. In 2019, they were added into the MIPS reporting program, and they're continuing to be included in the MIPS reporting program going into 2020. Now, a very important thing to know for MIPS is the low volume threshold determination. So there were no changes for the 2020 performance year. So how exactly does CMS determine if a clinician is included in year 4 for 2020? So first, they have to be a MIPS eligible clinician type that we saw on this previous slide, and then they have to exceed all three of the low volume threshold elements. So that's being that they have to bill more than $90,000 in a year for their allowed charges for their covered professional services under the Medicare physician fee schedule. They have to cover more than 200 services to Medicare Part B beneficiaries. And then they also need to provide more services to more than 200 unique patients during the physician fee schedule of that year. And now, an important thing to remember is that for MIPS APM participants, the low volume threshold determination will continue to be calculated at the APM entity level. So what exactly does that mean? So if you're a clinician that is enrolled in, let's say, a Medicare Shared Savings ACO, such as a Track 1, or now known as the basic track, and you don't exceed these thresholds, you would still be included in MIPS based on your APM entity. The APM entity will be that group of physicians that are in that Medicare Shared Savings ACO, and then CMS will look at, did they exceed all three of those low volume thresholds? Now, something that was new in 2019, and CMS is going to be continuing into the 2020 performance year, is the opt-in policy. So there was no changes for the 2020 performance period for the opt-in policy for clinicians who are excluded from MIPS based on the low volume threshold determination. So MIPS eligible clinicians who meet or exceed at least one of the low volume threshold criteria may choose to participate in MIPS. So as we see listed here on the screen, there are different scenarios depending on whether or not they exceed or don't exceed that $90,000 in Medicare billing, 200 unique beneficiaries, and then 200 services during the performance year. So as long as they exceed at least one of those criteria, they are eligible to opt in for MIPS, or they can also voluntarily report. So what's the difference between the two? So if they want to opt into MIPS, that means that they're opting in to be eligible for the payment adjustment. Now, that doesn't only mean that if they opt into MIPS, they'll only be eligible for the upward payment adjustment. So if they choose to opt in and they don't perform well in MIPS, they can face a negative payment adjustment. So that's definitely a decision that clinicians and practices would want to choose wisely on. Finally, again, if they do exceed all three of the criteria, so for the dollars, beneficiaries, and professional services, then they are required to participate in MIPS, as we can see in the last row of the table on the screen. To just give an example of the opt-in policy, we have an individual who's a physical therapist. So they billed $100,000 in Medicare reimbursement. So that's above that $90,000 threshold. They only saw 100 patients, which is below that 200 unique Medicare beneficiary threshold. However, they provided 201 covered professional services. So they just slightly covered more than 200 services, which is the requirement. So they did not exceed all three elements of the low volume threshold. Therefore, they are considered exempt for MIPS in year 4. However, if that clinician did choose to, they could opt in to participate in MIPS, meaning that they would then be eligible for that MIPS payment adjustment. So now how exactly can you verify whether or not you're eligible for MIPS? So luckily enough, CMS updates their QPP participation status every year. So you can actually log on today to see your 2020 eligibility by simply going to the qpp.cms.gov website and going over to the participation lookup to see if you're included in MIPS. So if you know your doctor's NPI or you have NPIs that you would want to look up on this tool, you can simply just plug them in there and then check all years, and it will give you the eligibility for that doctor based on all the performance years so far. So that will be from 2017, which was the transition year for MIPS, as well as that first year, up until this year, up until next year, 2020, which is year 4 in the new program for MIPS. So now I'll go ahead and pass over the ball to Madeline so that she can give you all an overview on the performance categories as well as some other information.
Hi, everyone. Thank you so much for joining us today. So kind of to give you an overview for the performance categories for 2020, we're going to go through all 4 of them, and then that will give you more of an idea of what to expect for the requirements for next year. So this is something that you're probably already familiar with, but this hasn't changed for 2020. So for quality, it's still 45%, as mentioned by Patrick. You're still reporting for the 12 months or the whole performance year of 2020. Cost category is 15%. That's determined obviously by the administrative claims done by CMS. So that's 12 months or the whole year. Improvement activities is 15%. You could choose any quarter or any 90 days that you wish to, just to meet the requirement for this category. The promoting interoperability is 25% still, and you still are able to choose minimum 90 days or any custom period that has the best performance. So kind of to go over now over the quality performance, we will be talking about the scoring and all of that that will be applicable for this year or for 2020. So some of the basics for 2020, it's still 45% as mentioned before of the overall MIPS score. You will be selecting 6 individual measures. One must be an outcome measure or high priority measure. So if an outcome, you would choose the high priority measure if the outcome measure is not available. So if you do have less than 6 measures that are applicable or that can collect data on from your practice, you can report on each measure that is available. However, you also do have the option to select like a specialty specific set of measures as well. So that's an option for some of the providers. And if you have questions about that, you can definitely let us know and we can help you with that. So in general, the goal of meaningful use, as you can see, is aimed to identify the highest priority areas for quality measurement and just quality improvement to assess the core quality of care issues that are like the most essential to advancing like our work to improve the patient outcomes overall. So for 2020, CMS is removing 39 quality measures, including those that are low bar, standard of care, and process measures. They're also adding new specialty sets, which include the speech language pathology, audiology, clinical social work, chiropractic medicine, pulmonology, nutrition or dietitian, and endocrinology. There will be a total of 218 quality measures that you can choose for 2020. So to moving on now to discuss the bonus points. So there's going to be 2 points for outcome measures or patient experience. So this will be after you choose the first required outcome measure or submit it. So that's what's going to be worth if you want to get extra points on your overall quality category. You can also get 1 extra bonus point for other high priority measures that are included. This also will be applicable after the first required measure is submitted, which is either the outcome or high priority. So that has to be first submitted before getting the other extra bonus points. After that, 1 point, can also earn 1 point for each measure submitted using electronic end-to-end reporting. And this small practice bonus for the quality category still applies, so you can still earn 6 bonus points. And so a quick reminder or a note to keep in mind is that a small practice is still defined as 15 or less clinicians in the tax ID. So kind of to go over now the data completeness. So for 2020, it did change a little bit. So instead of the 60%, now we're looking at 70% of your submission mechanisms. Obviously, this is applicable except for web interface and CAPS. Measures that do not meet the data completeness criteria will only earn 0 points, so you will not get any credit for that. So it's important to keep this data completeness requirement in mind to be able to achieve the maximum points for 2020. Small practices, if they don't meet the, if they don't meet the data completeness, they will continue to receive the 3 minimum points for the quality measures. So kind of to review the process of the measure removal for compared to 2019 to now 2020 and next year. So for last year, for this year, 2019, the way that CMS removed some of the quality measures, they focused on some of the quality measures were considered for removal if the measure was no longer meaningful, such as measures that are like tapped out. And you probably may have heard us mention that on our calls if you about some of the measures when it comes to selecting the best performance measures. They did remove a few for 2019, so that was the process for 2019. And they obviously added a few other requirements. So for 2019, as you can see, they do consider the way they were removed is if they were a measure was steward is no longer able to maintain the quality measure. So if we know that if that quality measure across providers that when they submitted and reported for the previous years was tapped out or capped out, they were no longer using the measure or were removed. And that did happen for some of our measures that we selected for this year for 2019 with our doctors. So in 2020, in addition to what the policy they already have implemented for measure removal, they also looked at the MIPS quality measures that are looking at the MIPS quality measures that do not meet case minimums and reporting volumes that are obviously required for the benchmarking or benchmarks in general for 2 consecutive years. So if that is the case, then these measures will be possibly removed as well for 2020. And that's how they kind of went through that whole removal process. CMS will also consider a MIPS quality measure for removal if they determine it is not available for MIPS quality reporting by or on behalf of all eligible clinicians. So this can also include the third-party intermediaries. So kind of to go over, this is new for 2020. Last year there was, for 2019, I know the year is coming to an end, but there was really no special benchmarking policy. The general benchmarking policy included the quality measures that were pretty much broken down into 10 deciles. And each decile has a value between 1 and 10 points based on stratified levels of national performance benchmarks within a baseline period. So a clinician's performance on the quality measures were compared to performance level in the national deciles, and that's how these benchmarks were ultimately determined. And the points were received were also based on the decile that matches the performance level in general, especially in the national level. For inverse measures like the diabetes hemoglobin A1C measure, the order is reversed. So the decile 1 starts with the highest value, and then decile 10 has the lowest value. What that means is that when you are looking at performance on a report that you generate from your EHR system, you ideally want your performance to be closer to 0 as possible, because that means that your hemoglobin A1C is actually controlled in the practice. So for 2020, they did establish a flat percentage benchmark in limited cases where CMS determines that the measure is otherwise applicable. Benchmark could potentially incentivize treatment that could be inappropriate for particular patients. So what this pretty much means is that if you have, for controlling high blood pressure, most of the patients all the patients that are applicable for this measure are hypertension, have hypertension. Or hypertensive. So sometimes doctors, do administer medications to be able to control the blood pressure. So in order to avoid the number of medications that are prescribed, the CMS kind of lowered the decile or the performance. As you could see at the bottom for hemoglobin A1C or measure 1, for 2019, you needed 2.68% performance rate to achieve the 10 out of 10 points. In 2020, that percentage that you need to achieve that 10 out of 10 is now 13.33%. So with that, you are able to achieve 10 out of 10. For measure 236 of the controlling high blood pressure, for 2019, you needed 100% in the decile to be able to achieve the 10 out of 10 points. And then for the year 2020, it's now decreased to 89%. So they kind of lower that to be able, for doctors to be able to achieve like the maximum points. And now moving forward to the cost performance category changes. So as mentioned before previously, the category is still worth 15% of your MIPS final score in 2020. The measures that are included that you're already familiar probably from last or from 2019 include the Medicare spending per beneficiary, the total per capita cost. There are for 2019 there were 8 existing episode-based measures, but for 2020 they added 10 new episode-based measures as well. So now there's a total of 18. There's really no reporting requirement, so the data is pulled directly from your administrative claims. And you'll be able to see your feedback that you get for the cost category after the window submission for MIPS in general. So the measured case minimums, it still remains the same for 2020. So the total per capita cost, you still need 20 patients. The Medicare spend per beneficiary is still 35 patients. Procedural episode measures, you still need 10 cases, and the acute inpatient medical condition episodes, you need 20. One thing to keep in mind is sometimes if you log on to view your feedback from previous years on the CMS website and you don't see a score for cost, you probably got like the whole full points. It's because this happens because in order for you to be scored on the cost measure, you or your group must have enough attributor cases to meet or exceed the case minimum for that cost measure. So it might be redistributed to other measures or to your quality points. So kind of to review the measure attribution. So in 2019, all the measures were attributed at the TIN and MPI combination level. So this was applicable for both individuals and groups. The polarity of primary care services also rendered by the clinician to determine attribution for the total per capita cost measure, and the polarity of Part B services billed during the index submission to determine attribution for the Medicare per beneficiary measure as well. So for 2020, the TPCC attribution will require like a combination of either for example, E&M services and primary care service or a second EMS service from the same clinician group. The TPCC attribution will also exclude certain clinicians who primarily deliver certain non-primary care services or are in specialties that are unlikely to be responsible for primary care services. So this could be applicable also to specialists. The MSPV clinician attribution changes will have a different methodology for surgical and medical patients, and the attribution will also be different for individuals and groups that will be defined in the applicable measure specifications. So we can, that is available as well. So they have, for each of these measures, more explanation on the attribution and the changes. So now to go over the improvement activities category. For 2020, this category weight is still 15% of the MIPS final score. You will still be selecting improvement activities and assessing yes, as you have submitted for the previous years for MIPS. However, one thing to keep in mind is that when you're assessing yes, you just need to make sure you have documentation for these activities that you do select, and just keep it in a folder on your desktop, or you can always print it out. The activity weights do also remain the same, so you can, the medium weight activities are 10 points and the high are 20 points. Small practices, non-patient facing clinicians, and or just clinicians located in rural or HPSAs continue to receive double weighting and report on no more than 2 activities to receive the highest score. So for this year, or for the next 2020 performance year, there were 2 new improvement activities that were added. 7 existing improvement activities were modified or changed by CMS. And then they remove a total of 15 improvement activities that were applicable in 2019. So this is important to keep in mind to kind of, for next year, if you were using some of these activities that were removed, for us to help you find other ones that can be used for 2020. So there's now a total of only 105 improvement activities that can be used. Or, yeah. So the improvement activity category, the definition of rural area for 2019, it meant that a zip code designated as rural would use the most recent health resources and service administration area health resource file data set available. So that's kind of what rural meant and was defined as for 2019. For 2020, this rural area means a zip code is designated as rural by the Federal Office of Rural Health Policy using the most recent FORHP eligible zip code file available. So in terms of the removal process of improvement activities for 2019, there wasn't really a formal policy that was in place for this removal of the improvement activities. For 2020, they did implement something now or propose for the final rule that an activity will be considered for removal if it is duplicative or of another activity. So if there's more, it's already similar to different ones that they already have included, then that means that it is likely that one of those activities will be removed. An alternative activity exists with stronger relationships to quality care or improvements in clinical practice. So if it already aligns well with another quality measure or a different activity that may be already redundant, so CMS also will be considering like removing the activity as well. For another thing is if the activity does not align with current clinical guidelines of practice, or the activity does not align with at least one meaningful measure area, or the activity in general does not align with quality, cost, or promoting interoperability performance categories. These are also going to be considered for removal. There hasn't been any cessation of activity for 3 consecutive years. So if no doctors are reporting on these activities for 3 consecutive years, then it's very likely that these improvement activities were already removed. And the activity is obsolete, so that's another factor that was implemented in the policy as well for this year, for 2020. So some of the requirements for improvement activity credit for groups, for 2019, the group or virtual group can attest to an improvement activity if at least one clinician in the tax ID participates. However, for 2020, the group or virtual group will be able to assess in the improvement activity when at least 50% of the clinicians in the group or virtual group perform the same activity. And that could be during any continuous 90-day period within the same performance year. So this will be for 2020. For the promoting interoperability category, there were a few changes. So it's still 25% of the final score for next year. You're still going to be required to use the 2015 edition certified EHR technology. So that is definitely a requirement to be able to report for this category. And the performance-based scoring at the individual measure level. So it's, in terms of the scoring and the reweighting, it's still the same process for 2020. And you are able to achieve a maximum of 100 total points for this for next year. So one set of objectives and measures based on 2015 edition certified. So before for 2017 and 2018, they had like the 2 sets, but not for this year, for 2019 and not 2020, they just have the 1 set of measures. And the 4 objectives, as you're already familiar with, includes e-prescribing, the health information exchange, which is broken down into sending referrals and receiving referrals. The provider to patient exchange, which is just sending invitations to the patients to be able to access their portal and view any documents, pretty much any information on their visit or encounter. And then the public health and clinical data exchange is still a requirement. And if you already enrolled for a few for 2019, you can still continue that enrollment, and that will meet the requirement for 2020 as long as you're complying with the registry. In terms of bonus measures, the Query Prescription Drug Monitoring Program, for 2020, it is also an optional measure, but they did remove the Verified Opioid Treatment Agreement, so that's no longer one that we can use for bonus points. And then to kind of go a little bit over the hospital-based eligible clinician in groups and what this means. So for 2019, a group was identified as hospital-based and eligible for reweighting when 100% of the clinicians in the group met the definition of hospital-based. For 2020, a group is identified as hospital-based and eligible for reweighting when more than 75% of the MPIs in the group meet the requirements. And for hospital-based individual MIPS eligible clinician. And overall, there was really no change to the definition of an individual hospital-based clinician. So this is just a list of the measures and points. For 2019, this was the way it was broken down, and for 2020, it will be continued to be, these measures will continue to have the same scoring points. So the security risk analysis, you will continue to assess and complete that every year. So you don't get any points for that, but you're just assessing, and you keep out, you'll be able to keep that assessment in a folder in your practice to be able to reference in case you need it for future, in the future. So for e-prescribing, that's worth 10 points this year. Or for the next year, 2020, in the prescription drug monitoring program, it's still like 5 bonus points. Health information exchange, the sending health information and the receiving, there's 20 points each. And the patient electronic access is worth 40 points. So for 2019, I know it was challenging to be able to like achieve like a maximum points for this patient portal, but for 2020, it will continue to be one of the measures or objectives that are worth the most. So it's important to continue documenting on that and inviting patients, if possible, to the, any patients that do provide you with the emails. So that's really highly recommended. So you can start early in the year. So you're still able to select 2 registries and meet the requirements. So immunization registry, electronic case reporting, public health registry reporting, clinical data, or syndromic surveillance registry. So to be able to earn the maximum points for the overall MIPS or promoting interoperability performance category, a clinician must use the certified electronic system for the performance period, at least 90 days or greater. So it could be any custom period or the any quarter in the year that's applicable, and you can always select the best performance points for those. You must submit a yes to the prevention of information blocking attestation, submit a yes to the ONC direct review attestation, and you also have to submit a yes for the security risk analysis measure as stated before. And you must report on the required measures under each objective or claim the exclusion if applicable. So exclusions still do apply if if you're not able to meet some of the objectives.
All right, so I'm gonna go ahead quickly into the different bonuses, the performance threshold, as well as the payment adjustments for year 4 of the quality payment program. So just to start there, it will still be available, the complex patient bonus. So this is up to 5 bonus points that are available for your practice and your clinicians to earn. So they get this earned based on the treatment of complex patients with a medical complexity. So it's a combination of that patient's HCC risk score as well as their dual eligible beneficiaries. So a MIPS eligible clinician, in order to get bonus points for the complex patients, they have to at least submit data for at least 1 performance category. So this complex patient bonus will be added to your overall MIPS score. So it's a little nice cushion that you can get if you know you are going to be lacking in another category. You can help, this complex patient bonus can help you push you to get just a little bit more of a higher payment adjustment in the end. Finally, there was a big change for the performance threshold for the 2020 program year. So the performance threshold increased from 30 points to 45%. Additionally, the exceptional performance threshold went from 75 to 85 points. And now, most importantly, the payment adjustment went from a negative positive 7% to be a negative positive 9%. So clinicians who do not report MIPS in 2020, but are eligible to report and are required to report, will face a negative 9% reduction in their Medicare reimbursements. So how exactly do those reimbursements happen, or how exactly will you receive your overall payment adjustment in 2022 based on your 2020 performance? So if you earn anywhere from 0 to 11.25 points, you'll receive a negative payment adjustment of negative 9%. If you earn above that 11.25 points, up until right under 45 points, you're going to receive a negative payment adjustment somewhere between negative 9% to 0%. If you score exactly 45 points, you'll be hitting the performance threshold, so you'll end up with a neutral payment adjustment. And then anywhere above 45 points, right to 84.99 points, you're going to be getting a positive adjustment greater than 0%. However, you're not going to be eligible for that exceptional performance threshold. Then finally, if you do score 85 points or more, then you are eligible for that positive adjustment, which is going to be greater than 0%, and then an additional payment adjustment for exceptional performance, which will be a minimum of 0.5%. And then finally, we just quickly wanted to point out that in 2021, what CMS does have proposed is that the performance threshold is going to be 60 points, and the additional performance threshold will remain at 85 points. So they're really having the minimum amount of points for the program increase to really increase the participation and then the quality of work that doctors are doing. Now, I'll quickly talk about reweighting in the targeted reviews. So reweighting due to data integrity issues. So we saw in 2019 that some doctors actually faced issues with their EHR systems. So we know EHR systems are really the backbone of the practice, especially when you do rely on them to keep record of all your patient visits, keep record of all your quality data, all your notes, which we know then does come into effect for MIPS. So if you do face issues with your EHRs or anything related to the data that you would be submitting for MIPS, CMS introduced with the 2020 final rule a data integrity issues exception. So what that means is, beginning with the 2018 performance period and 2020 payment year, you may have the option to get your performance categories reweighted for a clinician who CMS determines had data for performance categories that are inaccurate, unusable, or otherwise compromised due to circumstances outside their control of the clinician prior to the beginning of the associated MIPS payment year. So let's say if your EHR did have an issue during the 2018 performance year that limited your ability to report, and that actually hindered what you are able to report, or you may be facing a penalty because your EHR couldn't provide you the correct data, you can reach out to CMS to apply for this reweighting due to data integrity issues. So if CMS does determine that the reweighting is appropriate, they will follow their existing policies for reweighting. Now, finally, the targeted reviews. So some of you may not know what they are. However, what a targeted review is that when CMS provides your final score, if you think that that score is not accurate, you may initiate a targeted review with CMS. So what that means is that you're asking CMS to review your data that is submitted and for them to adjust your score based on the reason you're requesting a targeted review. So in 2019, targeted reviews were due September 30th. So that means that you had about 90 days to submit a targeted review in 2019 because the final feedback performance was available around July 1st. Now, beginning with 2019 performance period, so this means once you see your score in 2020 for the 2019 performance period, all requests for targeted reviews must be submitted within 60 days. So that's about a 2-month window. So depending on when exactly CMS does release your final score, you'll have about 60 days to respond or request a targeted review on your performance feedback. Now, looking ahead, so I want to quickly talk about MIPS value pathways. So CMS is really looking to reduce the burden on clinicians that are participating in the MIPS program. So with this value pathway, CMS is creating a new framework that would allow you to easily report on measures that do become related, so across all the performance categories. So what you'll actually see in the following slide are graphics provided by CMS that establish a value pathway, and what you'll see is gradually going into 2021, 2022, and so on, CMS is going to be working on aligning the different programs, the different performance categories that we currently report on into a more cohesive reporting. So it'll limit the burden on what you have to report on to become one cohesive reporting. So what exactly does that mean? So we know right now for MIPS 2020 and the previous years, there's many choices that you have to deal with in the program. So not everything is aligned. There are a few things that are aligned, but not overall in the program. So there's a higher reporting burden. So essentially, you feel like you're reporting still for 4 different programs for MIPS. So moving forward, what that means is that CMS wants to introduce a new MIPS value pathway. So that's going to be in the next 1 to 2 years. So they're going to be aiming to create a cohesive reporting that's going to be lowering the reporting burden and then focused on participation around pathways that are meaningful to a clinician's in practice specialty or public health reporting. So what that means is that they're building a framework for you to be able to report on fewer measures and activities based on your specialties into an outcome within what's going to be called a MIPS value pathway. So you can see right there in that middle graphic that is saying implementation is going to begin in 2021, and you can see how they're trying to align the different reporting categories. So they're showing that quality is going to begin to overlap with improvement activities, while also cost is going to overlap, and that's all going to be built on the foundation of promoting interruptibility and population health measures. And then the future state of MIPS, so in the next 3 to 5 years, they're going to be aiming to create a more simplified reporting method with increased voice of the patient, increased CMS provided data, so less data that you're going to be required to report from your practice, to really create a cohesive reporting. So you can see that now cost, quality, and IA will all be aligned together, and they'll build on that foundation of the promoting interoperability, population health measures. CMS will be providing enhanced performance feedback as well as patient-reported outcomes. And then finally, at the bottom of the screen, you'll see that they're trying to transition into more data being provided directly from CMS for your reporting and less data that has to be reported from your clinician or group. So less data that you have to collect during the year, less data that you have to worry about going through patients' charts, worrying that your EHR is set up to do the correct way and going to be giving you the right performance. So here's an example of the MIPS value pathway. So just because we're running a little bit short on time, I'm actually not going to go too deep into it, but we'll make sure that it is included in the slides. But essentially, this is a diabetes example. So what they're doing is you can actually look at the MIPS values pathway for diabetes, which is right here in the middle of the screen. You'll see that they have quality measures, improvement activities, and cost measures that begin to align with each other. So for example, you have a diabetic patient. Obviously, you're going to be looking at their A1C levels. You're going to be providing glycemic management services, and then that would fall into your Medicare spending per beneficiary. So now we'll go into the 2020 frequently asked questions. And then after that, we'll have a Q&A period. So to start off with number 1, where can I find an overview of the policies that were finalized for the 2020 performance period? So CMS provides an overview of the major policies that they finalized for the performance period on the qpp.cms.gov. So you can head to the resource section on that website, and you'll be able to see the final rule, that very lengthy 1,000-page document, but thankfully what CMS also provides is a fact sheet and a summary overview. So those are important to take a look at as they highlight the major changes and the key changes in the reporting program.
So the second question here is one of the top ones. Where can I find an overview of the policies? So this is kind of I'm sorry, this is redundant from the one previously. but CMS haven't finalized this, so any change to the weights of the cost and quality performance categories, the requirements for the registries to foster services such as educational services to clinicians or groups can improve the quality of care provided to patients. Both policies obviously will be revisited and altered for future rulemaking.
Yeah. So just to quickly adjust, the question that was supposed to be there is, were there any policies that were left not finalized with the year? So those ones that Madeline just covered, so CMS didn't finalize the change of the weights, the cost, and the quality performance categories. So you'll most likely see in the upcoming performance year of 2021 that the cost and quality categories will change. And then what she also covered is that the requirement for the registries to foster services such as educational services will possibly become a requirement for us. So us as a registry, we don't necessarily have to offer these webinars and the services that we do, but it is a benefit that we found for all the clinicians who participate in our services. So obviously we'll continue to offer those services for you all. So it looks like we're having a little bit of an issue for the FAQs that are listed there. So we'll definitely make sure when we do release the final set of slides that they are adjusted. But what this question was going to say is, did CMS propose any changes to the CERT requirements for 2020? So clinicians still need to report using a 2015 certified EHR technology for the 2020 performance year. All right, so this question did pop up correctly. So FAQ number 4, are MIPS value pathways required for 2020? No. So the MIPS value pathways are not something that are set in stone from CMS, and they're gonna be working on gradually implementing them into the program. So they are not something that you have to worry about for this 2020 performance year. They will begin possibly in 2021, and then they will continue to be rolled out through the future of the MIPS reporting program. So this question, we are scheduled to transition to a new EHR system during the performance period, but what does this mean for our quality measures for reporting? So we often face that practices decide to switch EHRs, and it may not be at the most opportune time. So obviously, if you are able to transition between EHRs, it would be best to do that at the end of the performance year, with then operating on the new EHR at the start of the next performance year. However, we know that that's not always the case, as you do have to work around your regular practice schedule and then also the vendor schedule as well. So what happens if you do undergo a mid-year transition? So if that does happen, you would have to get the reports from both systems and then aggregate them together, because for the quality performance category, you do need to report on a full 12 months worth of data for the performance period. So when you take the set of data from the one system for, let's say, 6 months, and then the other for the last 6 months, that will create that full year's worth of data. So how did scoring work in 2020? So what we quickly covered in our previous slide is that CMS scoring policies really pretty much stayed the same except a few exceptions. So we know that for the quality measures, you now have to make sure that your reporting rates are up. So you're going to have a 70% data completeness rate. There is the new introduction of that flat percentage-based benchmarks for measures like the A1C measure, as well as controlling high blood pressure. Finally, if you are doing group reporting and you're doing improvement activity, you have to make sure that at least 50% of your clinicians are performing that improvement activity. The performance threshold was updated to be at 45%. And then finally, to get into the exceptional performance threshold, that's 85 points and above, up from the 75 points for 2019. What's the max negative payment adjustment for 2020? So the max negative payment adjustment for 2020 will be a negative 9%. when will the historical quality benchmarks be available for the 2020 performance period? So CMS has yet to release those on their QPP resource library, but they will become available before the end of this year. So they'll become available before the start of the 2020 performance period, which is January 1st, 2020. So did they finalize a policy for group attesting to improvement activities? So CMS did finalize the policy. So that's what we just talked about. So if you are a group doing group reporting, you have to make sure that at least 50% of your clinicians are participating in an improvement activity. Now, they do not need to do it for the same 90-day period. However, they need to have been doing it for at least any 90 days during the performance year. Now, most importantly, how many points do you need to avoid a negative payment adjustment for the 2020 performance period for the 2020 payment year? So for the 2020 performance period, you need to earn at least 45 points to avoid the negative payment adjustment. And then also you can see on this table shown below the different performance thresholds to one, earn a positive payment adjustment, and then also reach that exceptional performance range. All right, so just quickly going into who NGI is with our services. So you know we are a qualified registry. We've helped many clinicians over the years report for MIPS. So we do offer different services. So we wanted to quickly highlight that our 2019 services are still available. So for anybody who has not registered for 2019 yet, we do advise you to register as soon as possible, especially because there are some key items that you need to make sure that you're meeting before the end of the year. So if you wanted to register with us today, you can go to that URL shown on the screen, which we'll also make sure to include in our webinar follow-up. Now, finally, we'll go into our Q&A session. So we apologize that we did take a little bit extended period of your time. However, if you're still on the line, we definitely welcome you to submit any Q&As to us. Okay, so one question that came in is small practices, the slide that specifies 15 or fewer eligible clinicians. So if I have a staff of 20, but only 2 are MIPS eligible, does that count as a small practice? I just want to double check. So a small practice is considered 15 or less clinicians in your tax ID. So if you have, let's say, 20 clinicians that are billing for Medicare patients, then you are not considered a small practice. So it needs to be 15 or less clinicians that are billing for Medicare patients to be considered a small practice. Another question that came in is, how do we know if we need to opt in or not, or if we do qualify? So if you don't exceed all 3 of those low volume thresholds, then you're exempt for MIPS. However, if you do exceed 1 of those 3 or 2 of those 3, then you are eligible to opt in for MIPS. Now, you don't necessarily have to opt in for MIPS. However, it's up to you if you would like to or not. So that's the last question that we do have in there. So if anybody is still on and would like to submit a question, please go ahead now. If not, we'll wrap up in about a minute or 2. So we do have a question just in follow-up to that opt-in policy. So how exactly do you opt in? So one, if you are reporting through our registry, you're going to see when you do submit your data to us, there will be questions about opting in. So if you are doing the opt-in policy, you would just identify with your submission that you are being opted into MIPS. If you are directly submitting to the QPP portal, there will be an option in there to identify that you're opting in for MIPS as well. All right, so if there's no other questions at this time, I'm going to go ahead and wrap up our webinar. So I do thank you all for joining today and then staying with us for a little bit of extra time. We know we did cover a lot of information today, so we will make sure to send out the slides as well as the recording of our webinar today. And one quick note as well, so if you still have to do your 2019 reporting or are not registered, we definitely want you to get registered right away so that we can get something scheduled with you and make sure that you're on track for 2019, moving into the new year when we do have to do your 2019 submission. All right, so I'll go ahead and close up the webinar. Again, I just wanted to thank everybody for joining today.